Good afternoon, ladies and gentlemen. My name is Zizeng. I am a second-year student in NUS's Master of Public Health program. For my day job, I work as a research executive for a charity home hospice service. I originally hail from Malaysia, and so I would like to take this opportunity to greet our guest speaker and everyone here. Selamat petang dan salam sejahtera. It is my pleasure to be your MC for today's dialogue. Now, for some housekeeping announcements. First, please ensure that your mobile phone is set to silent, and please refrain from consuming food inside the lecture theatre. Second, please note that we will be conducting photography throughout this event, and this session is currently being video recorded. Next, in case of a fire or emergency, please do not rush down from the staircase as the steps are very narrow, and do not leave your valuables unattended. Do keep calm and do take note of the exit points, which are at the front and at the back of the auditorium. Please follow the escape route, which is currently shown on screen. You may follow our ushers in an orderly manner and assemble at the multi-purpose field. For guests who would like to connect to the NUS Wi-Fi network, please follow these steps. Feel free to take a photo of this slide in case you need to refer to it later. For today's Q&A session, after the panel discussion, we will be using Pigeonhole, where you can submit your questions. To participate, please scan the QR code that is currently shown on screen. Alternatively, launch your internet browser on your mobile device and enter www.pigeonhole.at into the address bar. Thereafter, key in our event passcode, 89M for Malaysia, 598, shown on the screen. When you are logged in, please provide your preferred name before you begin to submit questions. There is also a voting feature, so questions with the highest number of votes would be highlighted to the speakers and stand a better chance at being answered by the speakers. Alternatively, should you prefer to raise your questions directly to the panel of speakers, there are microphones positioned along the steps. Minister of Health for Malaysia, Mr. Khairy Jamaluddin, NUS President, Professor Tang Eng Chai, distinguished guests, colleagues, and friends. A very good afternoon and welcome to the Public Health Thought Leadership Dialogue presented by the Saw Swee Hock School of Public Health. As the world continues to grapple with the pandemic, health systems everywhere must tackle other public health challenges that are just as real and just as important. New trends in communicable and non-communicable diseases, healthcare that grows more complex and more fragmented, issues around equity, sustainability, and precision. Clearly, it cannot be business as usual. Healthcare must respond. What lessons will we learn from past efforts? How do we adapt to the current situation? Can we prepare ourselves for future complexities? With that, we are delighted to have with us today our guest speaker, Minister of Health for Malaysia, Mr. Khairy Jamaluddin, as well as our panel of distinguished experts to discuss future-proofing public healthcare. I would now like to invite the Vice Dean for Global Health at Saw Swee Hock School of Public Health, Associate Professor Su Li Yang, to say a few words and introduce our distinguished speaker for today's session. Associate Prof. Su, please.
Selamat petang semua orang. Minister Khairy Jamaluddin, Professor Tan Eng Chai, colleagues and distinguished guests, it is my pleasure to welcome you to the 10th edition of our Public Health Thought Leadership Dialogue, which focuses on major health issues that impact our local and regional populations. As we reach this major milestone for the dialogue, we are truly honored to have a very distinguished visitor, Malaysia's Health Minister, Mr. Khairy Jamaluddin, to deliver the lecture today. Malaysia and Singapore share a history that extends beyond economic ties, with common borders and many cross-border families, a mutual dependence on water and food security, and even very serious disputes about the origins of hawker dishes. The health and well-being of our people are also linked. The most recent example being the COVID-19 pandemic, where the causeway was closed, that comes to mind, but the Nipah virus outbreak is still within living memory. That outbreak led to an import ban on Malaysian pork for 16 years. And I think most of us here fervently hope that the export ban on Malaysian chicken will not last quite as long. We also study and learn from the health policies and interventions from both countries. And we in Singapore will be looking very closely at a generational endgame legislation that is due to be introduced in July in Malaysia's parliament, where smoking and possession of tobacco products will be banned for those born from 2005. The National University of Singapore works closely with multiple Malaysian universities. The faculty of my school have been partners with the Public Health Fraternity of the University Malaya in the Asia-Pacific Academic Consortium for Public Health that oversees research, capacity building, and public health practice in the Asia-Pacific. Next week, we'll be co-organizing a seminar on women in global health with where Professor Adiba Kamaruzaman will speak on her life's work on HIV and AIDS. We've also initiated Advanced ID, a regional network for clinical and epidemiological research in infectious diseases that will involve several hospitals in Peninsular and East Malaysia. This is led by Professor David Patterson from our school and is supported by prominent Malaysian clinician researchers. But enough from me. It is a distinct privilege and honor to be hosting Minister Khairy here, especially so soon after the reopening of our mutual borders. He is the current Minister of Health for Malaysia, having previously served as the Minister of Science, Technology and Innovation, as well as the Minister of Youth and Sports. Prior to entering politics, he worked as a policy aide, investment banker, and entrepreneur. He was chairman of Malaysia's National Entrepreneur Development Corporation, deputy president of the Football Association of Malaysia, and also co-founder of The Centre, a think tank dedicated to the promotion of centrist thought. All these by the age of 46 years, which makes me reflect a little bit on what I've done in my life. With such a diverse and breadth of experience and knowledge, I can think of no one better to speak on future-proofing public health. Minister Khairy, may we invite you on stage, please.
Assalamu alaikum wa rahmatullahi wa barakatuh, and a very good afternoon. Thank you, Associate Professor Su, for that very kind introduction. I just wanted to add that during my visit, I'm abstaining from eating chicken out of courtesy to my hosts. Professor Tan, President of National University of Singapore, ladies and gentlemen, thank you very much to the NUS Saw Swee Hock School of Public Health for inviting me to speak today at this Public Health Thought Leadership Dialogue. I'm very happy for this opportunity to come to one of Singapore's most respected public health institutions and share with you on how Malaysia is addressing challenges in public healthcare. I'm also gratified to be in Singapore on a work visit. I'm actually here as a Lee Kuan Yew Exchange Fellow. It's a long-running exchange fellowship where they invite members or politicians and leaders from other countries to come and visit. I'm the first Lee Kuan Yew Exchange Fellow since the pandemic, and I suppose it's appropriate that the first one should be Malaysia's Health Minister, and that is also a sign of confidence in, of course, our border opening. It's certainly good to be back in Singapore. In this regard, before I continue with my lecture, I would like to take this opportunity to pay tribute to the outstanding professional working relationship that has developed between Minister Ong Ye Kung, Singapore's Health Minister, and myself. The decision to open our border was not an easy one, especially the causeway, which is one of the busiest land crossings in the world. We knew once we advised our respective prime ministers that the time had come to open the land border, we would effectively become one epidemiological area. We had to trust each other's judgment and trust in each other's pandemic response and data. In the weeks and days leading up to the announcement, Minister Ong and I consulted each other almost daily until we were both able to make the crucial judgment call. I learned much from his analysis of the situation, and we are now both extremely relieved that the reopening between our countries has been done safely. Ladies and gentlemen, the title of the lecture today is Future-Proofing Public Health Care. Now, this sounds extremely aspirational, perhaps overly so, and some of you would be right to ask what we mean by future-proofing when we're already having to address the so-called problems of tomorrow today. Amongst other things, we're seeing the very real effects of rising non-communicable diseases, or NCDs, together with population aging. A large proportion of the population has multiple risk factors and morbidities, such as obesity and diabetes. 10.7% of the population in Malaysia is now 60 years and above. Malaysia will technically become an aged population by 2030. Mental health problems are also a growing healthcare challenge in Malaysia. The 2019 National Health and Morbidity Survey showed that 2.3% of adults may suffer from depression, and that 7.9% of children aged 5 to 15 years may also be experiencing mental health problems. The rates are no doubt higher today due to the effects of the pandemic, evidenced by the spike in the numbers of people seeking mental health support. These coalescing forces have gradually but materially changed the nature of demand for health and social services, not to mention the costs. In addition to existing demand for treatment of severe and acute cases, there is an increased need for long-term management of morbidities and disease. There are greater calls for more people-centered health services, both for those without strong family support systems, as well as for those who may safely manage and age in place. Bit by bit, by degrees, the concept of what constitutes public health care has become very much expanded, and the line between healthcare and social care increasingly blurred. We are also seeing the very real effects from deterioration in environmental balance and planetary health, another problem of tomorrow that is, in actual fact, already here with us. The last 2 years have been spent battling a global pandemic started by a zoonotic coronavirus, an infectious pathogen transmissible from animals to humans. The frequency of such fast-spreading zoonotic diseases such as COVID-19, SARS, and MERS in this last decade alone highlights the impact of changes in land use, increasing urbanization, and global connectedness. According to many environment and health scientists, and all of you know this, the question of another global pandemic in the foreseeable future is not a matter of if, but rather when. Climate change and extreme weather events, driven by the rise in global temperatures, will similarly increase the spread of zoonotic viruses as well as waterborne pathogens. The frequency and severity of flood events in Malaysia, for instance, has increased in recent decades, giving rise to greater risk of infectious diseases on top of population displacement, as well as loss of lives and livelihoods. So what does future-proofing mean when these issues and challenges are actually here today? As a minister and policymaker, to me it means expecting, preparing for, and mitigating the very likely acceleration of these forces that we are seeing today before it brings us to near breaking point. As humans, We expect the speed of acceleration to be linear, when in reality, the pace of change is very often faster than that, and sometimes exponential, hitting us intensely and at great numbers all at once. My colleagues and I at the Malaysian Ministry of Health have long been concerned about sustainability. There are enough indications that our healthcare system is struggling to meet the current health needs of the population, problems faced by many countries around the world. This situation naturally worsened during the pandemic when there was a sharp surge in demand for healthcare that overwhelmed the healthcare system. The situation is gradually normalizing, and thank God, no doubt driven by our focus on vaccination and the SOP, or standard operating procedure, adherence of our population. Nevertheless, the pandemic has brought many issues into sharper focus, not least issues of sustainability and how prepared we are for the future. On this score, the systems that we have today are arguably stuck in paradigms of the past, modeled on population profiles and ways of working that no longer serve us. Incremental improvements to old models no longer suffice. Future-proofing requires us to make some significant structural changes to the way the healthcare system is organized, financed, and governed. We need to build back better towards resilience, towards a resilient health system that is capable of absorbing shocks such as public health emergencies, of managing demographic challenges like an aging population, and dealing with the effects of climate change. In Malaysia, we look to Singapore's public healthcare initiatives with great interest, particularly the changes in financing, benefits coverage, and service coordination implemented in the last 10 years. We can appreciate the weight and complexity of the undertaking, as well as the phasing involved, though I must confess here to a measure of policy-making envy for Singapore's geographical size and population density compared to ours. As some of you may know, Malaysia is in the midst of developing a health white paper aimed exactly at making the case for structural changes, as tough as they may be, to future-proof our healthcare system. Today, I would like to touch on 4 broad areas of reform that we are currently considering. The first is equitability of access. What does future-proofing equitability of access mean for Malaysia? Knowing what we do about the forces shaping healthcare needs long-term, it means balancing foresight with pragmatism in redefining what universal coverage of basic medical services entails. Is mental health support, for instance, part of what we consider to be basic medical services? And if yes, to what level? What about long-term rehabilitation and therapy? What about the provision of medication, expensive cellular and gene therapy, devices, and equipment? On top of questions of breadth, what kind of quality aspects should basic medical services cover? Maximum waiting time KPIs for follow-ups and treatments for patients of different risk profiles, brand name pharmaceuticals, smooth referrals and minimal form filling, patient-centered care delivered by, for example, mobile teams and home visits. Now this the new vision for basic medical services. Answering these questions require us to be honest about the trade-offs involved, as resources are not infinite. Some matters of equitability are and will continue to be non-negotiable. For example, reducing the regional gap in healthcare facilities, equipment, and manpower, particularly in the Malaysian states of Sabah and Sarawak on Borneo, and also certain interior districts in the peninsula. Another related matter that is non-negotiable is ensuring that there are sufficient trained and motivated doctors, specialists, nurses, allied health professionals, and other healthcare support or ancillary workers to deliver the services that are needed. For other matters, though, we must assess the benefits of coverage against the estimated costs, both financial and non-financial. This challenge, of course, is not unique to Malaysia. Indeed, many other countries, especially in our part of the world, face the same concerns. But having a clear framework for this cost-benefit assessment is key. Future-proofing equitability of access means we must also be efficient in how we achieve our ambitions of coverage and quality within the ecosystems in which we operate. Malaysia's dual healthcare system, comprising both public and private healthcare providers, ensures a reasonable level of physical access for the majority of the population. Both are important players in Malaysia's healthcare delivery system. While private providers tend to be in urban areas, the public healthcare sector is fundamental to Malaysia's health ecosystem, with an extensive network of public health and disease surveillance services, clinics, and hospitals that are spread across the country, and mobile health teams serve in areas where physical facilities are not feasible. Nevertheless, I have to admit, the public and private sectors are not yet well integrated. Malaysia's dual healthcare system is largely dichotomous, with the primarily tax-funded public sector on one hand, and fee-for-service private sector providers on a parallel track, funded primarily via for-profit private insurance and out-of-pocket payments. The public sector caters for 2/3 of outpatient and inpatient cases, but 75% of specialists in Malaysia are in the private sector. Resources, burden of work, and data are not easily shared between the two sectors, leading to delays in diagnosis and treatment, unnecessary repeat investigations, and added costs. During the pandemic, these twain tracks did meet, when under emergency conditions, the government procured services for public vaccination from private GP clinics and sent non-COVID cases, decanted them to private hospitals. We decanted non-COVID patients from public hospitals to private healthcare facilities when we hit surge capacity during peak Delta. And even today, we have continued this approach to reduce some of the public sector's case backlog. We had something like 50,000 surgical and medical cases which were delayed because of the pandemic, and bringing together the public and private sector in massive surgical initiatives, we've been able to lower this to about 30,000. We plan to expand such public-private partnerships further so that we can effectively maximize all the existing healthcare capacity in Malaysia, including those from the non-profit sector, in a way that reduces service dark spots and waiting times while making sure that costs are contained and fair. Close partnership between sectors can also increase treatment options for our lower and middle income groups, including oral health services and traditional and complementary medicine services, which are mainly driven in the private sector. To future-proof this for Malaysia, however, several structural changes need to happen, including development of feasible payment models, strengthening of strategic purchasing, ensuring good demand mapping, as well as putting in place better processes and tools for referrals and consultations, including shareable electronic medical records. These are just some of the structural reforms needed to implement greater public-private partnership sustainably and ultimately deliver better equitability of access in the long term. But one note of caution, more public-private partnership does not mean that service quality in public facilities remain at current levels. In fact, future-proofing equitability of access requires us to ensure that public sector hospitals and clinics are set on a path of significant and lasting service improvement. As a first step, one of the key structural reforms that Malaysia is currently studying is to grant greater operational autonomy to our public hospitals so that these overburdened and constrained flagship institutions are given the room to be more responsive to the changing needs of the population. We intend for this change to also facilitate better integration and public-private partnerships. And in the long run, this would allow the Ministry of Health to focus on policy, regulation, research, public health surveillance, and interventions while devolving service delivery. Ladies and gentlemen, in these last few months, my ministry has been holding stakeholder engagement sessions with a diverse range of stakeholders to discuss respective groups' wish lists and priority areas for the upcoming health white paper. Now, compared to a few years ago, although the feeling was already there is now even a greater recognition that the public healthcare system in Malaysia is chronically underfunded, and that how the system is financed plays an important role in advancing universal health coverage. Underfunding has resulted in a plethora of issues, from understaffing to badly maintained infrastructure to outdated equipment. With limited publicly managed funds, opportunities to integrate the public and private sectors through strategic purchasing is also severely limited. All these issues contribute to high out-of-pocket payments, and although Malaysia has relatively low incidences of impoverishment due to catastrophic health spending, out-of-pocket payments is still very high compared to other upper-middle income countries at 34.5% of total health expenditure as of 2020. These levels of out-of-pocket payments are a major concern, especially when we have a high prevalence of chronic diseases, as it would likely lead to delays in treatment and greater illness due to cost avoidance. Thus, for many years now, there have been constant calls and consistent calls for a healthcare financing model that is dedicated, sustainable, and progressive. But as many healthcare policymakers will tell you, that is easier said than done. I was told that one stakeholder had even quipped that equitability is expensive. There is more than a grain of truth to that remark, particularly given the steady inflation of healthcare costs, which is itself due to market failures in the healthcare system. And so, a critical area of reform we are currently considering as part of the Health White Paper is, not surprisingly, healthcare financing. Almost 10 years ago, in 2013, Singapore's finance and health ministers embarked on a significant review of Singapore's healthcare financing framework towards having the state shoulder a larger share of the healthcare costs that had been, up to that point, predominantly borne by patients and households in co-payments and other market mechanisms. Malaysia is also at that critical juncture in terms of rethinking healthcare financing, though our current circumstances are very different from Singapore's. While Singapore's public healthcare has a financing model that consists of tax-funded subsidies, a medical safety net fund, Medifund, a mandatory basic healthcare insurance, MediShield Life, as well as a national medical savings scheme, MediSave, Malaysia's public healthcare sector is predominantly, if not fully, funded by federal government taxation. In the medium term, federal taxation will likely continue to be the main or anchor source of healthcare funding for Malaysia due to its inbuilt equity. But the question before Malaysia and before me running this now is, will relying on federal taxation be sustainable in the long term? And what would future-proofing healthcare financing look like for us? The answer to the first question is, of course, no. It's no longer sustainable, and the system will break. Since the onslaught of the pandemic on lives, livelihoods, on our collective sense of security, financing healthcare is increasingly being seen as an investment rather than an expense. Indeed, investment in the healthcare system should be perceived as an investment for the country's development, just like investment in education. On this note, raising the government's allocation on healthcare spending is an option being discussed seriously with my cabinet colleagues, especially as Malaysia's total healthcare spending to GDP ratio at 4.7% is far below the middle income country average of 6.6%. If you strip that and you look at Malaysia's spending on public sector healthcare, it is at 2.6% of GDP, also below the average of 4% GDP amongst middle-income countries and below the 5 to 6% recommended by the World Health Organization. At the same time, I need to be realistic. Increasing the allocation from the federal government budget has its limits and constraints, particularly in the medium term. As the economy recovers from the pandemic, we're confronted with the specter of possible global stagflation and extremely tight fiscal positions. The healthcare fund must be sufficiently large to fully harness the power of risk pooling, effectively spreading the risk amongst individuals who are healthy with those who have pre-existing conditions, a group who today would either not be eligible for private insurance coverage or who would not be able to get affordable coverage given their high risk. So if we want to future-proof Malaysia's healthcare system that provides equitable access to better quality health services in the long term, including better preventative and promotive care, we need to have a dedicated healthcare fund that is both tax-funded and that is supported by contributions from the people who can afford to do so, be it in the form of co-payments or social insurance, or a combination of these progressive contribution methods. And this is easier said than done. This is a huge and tough political call. For equity, contributions into the healthcare fund should be on a sliding scale, in line with an individual's income, and be fully subsidized or waived for low-income groups. These principles are not new. They have been discussed and debated in Malaysia for the last 20 years, if not longer. But I think the COVID-19 pandemic has lifted the veil and shown the true human costs of not resolving this issue. Even the sliding scale is controversial. Where does the scale stop sliding? And where does it start getting subsidized? That has been exacerbated by the pandemic as well. Now, one of the critical missions of the Malaysian Health White Paper, therefore, is to put forward a statement of intent on how the country's healthcare model can be put on a sustainable footing, at the same time addressing past legitimate concerns on the architecture, phasing, costs, and governance of this particular reform, which affords me an opportune segue to the next broad area of future-proofing, which I'd like to talk about today, which is governance and accountability. The structural reforms I mentioned earlier, such as, amongst others, establishing and strengthening a strategic purchasing function or development of payment models, all these reforms will need processes and reporting lines that ensure each function has accountability to taxpayers and contributors. There may be some increase in administrative costs, but I believe that this will be manageable if we emulate global best practices and ultimately be worthwhile if access and health outcomes are improved. We can always look at the leanest bureaucracy that delivers on health insurance. More broadly, though, the work of policymaking occurs not in a sedate vacuum, but in a complex multi-stakeholder political economy. And there is no question that the policymaking environment has become increasingly polarized and unpredictable, which makes the work of structural reform even more challenging. How do we future-proof the reforms itself, the ones that we have so carefully benchmarked, debated, and refined, some of which over literally decades? How do we ensure that long overdue structural reforms are followed through, that we do not let the country lose more time and more lives in stopgap measures, regardless of politics or who the health minister is or which government is in power? When I started this process of reform in the white paper, my biggest concern was new minister, new white paper, new minister, new vision, new minister, new reform. Apart from ensuring that the Ministry of Health consults as diverse a range of stakeholder groups as we can, what I thought we could do to make sure that the reforms themselves are future-proof is that we will be seeking bipartisan support for the proposed reforms contained within the Health White Paper by tabling this to Parliament. To be clear, there will still be many details and plans of action that would need to be worked out in the immediate coming years. But by having bipartisan agreement, a national green light, if you wish, on the overall principles and direction of structural reforms for Malaysia's healthcare system is absolutely critical. Not only would it cement the moral and political standing of the proposed reforms to span a period of 15 years, in a larger sense, it would also show us as a country that we can come together when it matters and set aside our differences to be on the right side of history as far as healthcare is concerned, no matter who wins the next election. And in Malaysia, elections are contested very competitively, as you know. Of course, accepting the principles and direction of reforms is one thing, but the biggest challenge is ensuring follow-through, and that's another matter entirely. And we've thought about this. To further future-proof our reforms, the Healthcare White Paper will also be proposing the establishment of a Healthcare Reform Commission, whose task will be to independently monitor, advise, and report on the status of reform implementation to the government, to the parliament, and to the people. Having a transparent and well-appointed Healthcare Reform Commission would, I hope, inject a level of institutional check and balance and stability into the healthcare political economy, supporting structural reforms no matter what the future holds. Ladies and gentlemen, finally, we can't be complete in talking about future-proofing if we do not talk about genuinely bringing health back into healthcare, because right now it is more sick care. I'm speaking here about the need to shift from a curative and treatment-focused mindset to a focus on wellness and on preventative or promotive healthcare. Part of the major work here is, of course, strengthening the resourcing and policy attention on primary care towards becoming more holistic, with multidisciplinary teams monitoring and ensuring early intervention amongst local families and communities. In this era of chronic disease and an aging population, primary healthcare is better positioned to provide closer care to the community. Singapore's recently announced Healthier SG initiative is very much in line with our thinking on this front, and we hope to learn from your experience in enrolling every resident to a regular family physician and setting up individualized health plans. Another major plank of this work is to acculturate health and wellness into the population until certain practices become the norm, such as regular exercise, good nutrition, regular health screening. Next month, I will be traveling around Malaysia to launch our national screening initiative in collaboration with various parties such as the Ministry of Family and Women Development, Social Security Organization, the private and civil society organizations. A lot of people have missed out on their health screenings over the last 2 years with no baseline. We were targeting 1.5 million Malaysians over the age of 40 who have never had health screening to be screened over the next few months. We want to nudge and encourage our population to continuously take steps towards better health and self-care. Community empowerment is, of course, an extremely important component, and part of the structural reforms is to work more effectively with civil society organizations and community change agents in order to increase health literacy, as well as to address barriers rooted in social determinants of health. Because let's face it, half your health outcomes come from things other than health. So we need to look at income, poverty, education, housing, the local environment, the built environment, and so many other things. Nudges and campaigns are not enough when there are structural obstacles in the way of better public health outcomes. Asking people to eat healthy is difficult when they can only afford fast, processed food. Asking them to exercise regularly is futile when they are juggling multiple jobs and side hustles just to keep up with the cost of living. We need to reimagine the built environment, urban planning, waste management, other non-health determinants of health. I've reminded my public health officials that public health officers are social justice warriors, and they were social justice warriors previously. They need to bring back the spirit of seeing health in all policies and become advocates for health across government, throughout society, in each individual ministry and agencies and really bring down the socioeconomic barriers to better health outcomes. In this regard, we started, similar to Healthier SG, Agenda Nasional Malaysia Sehat, or Healthy Malaysia National Agenda, which is a cross-stakeholder, whole-of-society platform that was set up last year involving all the ministries, private sector organizations, civil society organizations, and to strengthen the programs and partnerships together with the community by changing the way we live, not just in terms of the healthcare system, but every other determinant that is important to healthcare outcomes. I'm also bringing to our Parliament next month a landmark legislation which, if passed and enforced effectively, can result in significantly better health outcomes for many years to come. While the idea is not new, Malaysia hopes to be the first country in the world to enact a tobacco generational endgame. If this law is passed, Malaysians born after 2005 will never, ever be able to buy or use any smoking products anymore. The end. The end for smoking and tobacco. And while there are those who believe that banning is never the solution, I am determined to make this work. Ladies and gentlemen, I have shared with you a long list of structural changes that we mean to undertake, but I would be remiss in leaving out credit and acknowledgement where it is due. The fact is, Malaysia has achieved tremendous health outcomes over the year. We have provided very accessible and affordable healthcare to the majority of our population. We have been recognized by several global health authorities and researchers as early in the 1980s as a country providing universal health coverage, a commendable achievement given our GDP, population size, spread over a varied geography of 330,800 square kilometers in 2 separate land masses. However, we are indeed seeing the so-called problems of tomorrow gather pace today, and like many other countries around the world, we would not like to see our healthcare system and our people brought to the brink of breaking. COVID-19 has been our wake-up call, the opportunity for a big reset, and we must put in place long overdue systemic reforms today. Some reforms go beyond the national level. Indeed, on a global scale, much more international consensus and cooperation is needed. Malaysia values the international cooperation between Singapore and us in handling public health emergencies and many aspects of sharing information, lessons, and experiences. We need to work together to ensure a global health architecture that is inclusive, accountable, equitable, better coordinated, and transparent so that the world is better equipped to respond to future pandemics in an ever-connected world. I was in Geneva recently looking at the proposed amendments to the international health regulations. Yes, countries should be accountable to disclose key information of public health concerns. We agree with that. And that was a lesson from COVID-19. But companies should also be made responsible to disclose intellectual property and manufacturing know-how of vaccines, diagnostics, and therapeutics in emergency situations. Malaysia is also taking the lead in global equity by shining a light on neglected diseases. The world witnessed how science and finance will galvanize to develop the COVID vaccine in mere months. But we can do this for so many other diseases. Malaysia is taking part now in clinical trials to repurpose therapeutics to treat dengue, a disease that remains endemic in our part of the world for so many years. We have also fought for cheaper, accessible treatment. In August 2017, the Malaysian cabinet decided to make available affordable generic versions of the hepatitis C cure, sofosbuvir. In June 2021, Malaysia became the first country in the world to be given conditional approval for ravidasvir in combination with sofosbuvir to treat hepatitis C patients, which brings a cure rate of 97% and a cost reduction of 95%. And we will continue to work with partners like the Drugs for Neglected Disease Initiative to bring more affordable medicine to the global south. In the interest of time, let me wind up my speech. There are several other areas of future-proofing I elected not to get into. For example, how to better integrate healthcare with social care, particularly for the elderly. Another area is improving planning, training, career development, and working conditions for health workers, not just for doctors, but nurses and allied health professionals. Yet another area is a greater adoption of digital technologies, not only for remote consultation or outbreak surveillance, but also for precision medicine and self-health monitoring. But I shall save this and other questions you may have for the discussion to follow, for which I'm extremely looking forward to. Thank you very much.
Thank you, Minister Khairy, for sharing your insights. What particularly resonated with me were three themes: coordination, community, and vision. And I'm very excited to see what all the experts will share further later. Next up is the panel discussion and question and answer session. With us today are the panelists, Minister Khairy, Dr. Sian Lei, CEO of the American Chamber of Commerce in Singapore, Dr. On Suan Yi, COO and Senior Health Systems Researcher for Research for Impact, and this session's moderator, Associate Professor Jeremy Lim, Director of the school's Leadership Institute for Global Health Transformation, LIGHT for short. Thank you.
Thank you very much. Minister, thank you for that tour de force. I know you've spent a lot of time on this, so I'm going to give you a minute or two to chill a little, right? And I'm going to ask our two panelists to take a minute each to reflect on what in your speech, what in your sharing most resonated with them. Yeah, and maybe we'll start with Sian and then we'll go to Swan.
Well, thank you very much, everyone. It's such an honor to be on this panel with you, Minister. And thank you, Jeremy and Swan, for having me here with you. I think now you know my bio, which is I'm the CEO of the American Chamber of Commerce. We represent about 600 companies here in Singapore. Many of them obviously are American. So my role here, although at heart I am a public health scientist, I'm an epidemiologist by training. So shout out to all the epidemiologists in the audience. Very good. I'm with the right crowd. But you know what? At heart, I'm a public health scientist, but I've been in the private sector now for many years. And so on this panel, I will be representing the views of the private sector. And one of the themes that the minister mentioned in his excellent speech covered so much ground, but one of the themes that came through very strongly is this need for public-private partnerships. Now, some of us in the audience today are from the private sector, and we have tried for many years to make public-private partnerships successful. It is not easy to do because each side has a different agenda. And in fact, these PPPs, I think we need to perhaps think of it in a different way if we're going to talk about the future of public health, the future of healthcare. So you take these three Ps, they could actually stand for a different focus. The first P being products, the second P being platforms, and the third P being processes, all of which the minister touched upon in his speech. On the product side, we're talking about innovations in therapies and technologies and pharmaceuticals and diagnostics. And what we need in this case, advocating on behalf of the private sector, is the ability to provide access to those who need these products and to make it easier for us to achieve this access on behalf of the patients and the population. The second P, in terms of platforms, is something we all like to talk about. I'm wearing an Apple Watch today, so platforms that allow us to help improve the public's health, to use these technologies and take the data from them to create platforms that take that cure focus into preventative focus. And finally, the third P I want to emphasize in this three Ps of public-private partnerships would be processes. Now, Minister said a couple of times something that I think strikes fear into the hearts of some of us who've had to negotiate before, which is strategic purchasing. Now, we call it procurement, and it can be very nerve-wracking, but if you start thinking about strategic purchasing, regulatory, from a different angle, which is when it comes to innovation, regulators, those who are in charge of strategic purchasing, are here to enable us so that we can find that right balance to get these products out into the market so that those who need it have access. I think if we change our mindset and our relationships in that way, we're on the right track. And thank you so much for this speech because it inspired a lot in me, and I feel really motivated to continue working on behalf of the private sector here in Singapore and in the region. Thank you, Minister.
Thank you, Sian. You're always welcome back to public health care. Swan, please.
Hi, thank you so much to the school for having me. It's an honor to be up here, both as a Malaysian and as an alumnus of the school twice over, perhaps too many times over. Thank you very much, YB Khairy, for your speech. I think you've covered so much ground, and it really highlights that when we want to future-proof healthcare, we can't think about it in silos. We really have to think of all these issues as intertwined, whether we like it or not, and requiring a lot of collaboration among different parties, whether we like that or not either. So there are a few things that struck me very much from what you've shared, Minister. The first is your point on equitable access and how you talk about very many aspects of basic health coverage and what Malaysians should have access to. So you talked about mental health, rehabilitation, and so on. But I think something that we should be considering as well, especially as you've highlighted the aging population, is how to age well, live well, and also die with dignity, which is something that Singapore is looking at very closely as well. The two countries look to each other for a lot of different advice and thoughts, and this is one place that we could maybe work together a little bit more closely, because Singapore is a little further along on the aging population side of things than Malaysia is.
Yes, Swan, we're old, we know that.
It was not meant to sound like that, Jeremy. I'm not that young either. Regarding what you said about public-private care integration and how the pandemic kind of accelerated that moving forward, I'd like to hear a little bit more from you, if possible, about what you think of how this could continue even beyond the pandemic, because the pandemic catalyzed a whole bunch of change. But you've mentioned this in another, at another event where you spoke at, you said there was some issues like NCDs and climate change or tragedies of the horizon. And once we are out of the very acute phase of the pandemic, which we are sort of exiting at the moment, what happens when things settle down and we sort of gently settle back into business as usual, even though we shouldn't be? I'd also like to raise a point about healthcare financing and how Malaysia is at this critical juncture where we do have to make some very major structural changes, which I absolutely agree with, couldn't agree more. However, there are questions that remain around the acceptability of new models of financing for the Malaysian public who are still recovering from the economic impacts of the pandemic and are currently struggling with things like the weaker ringgit, increasing costs of food, petroleum, and so on and so forth. So these things factor into their willingness to, for example, accept something like a MediSave account, which is, which the government thinks is a good idea, but may not be necessarily understandable or achievable as something that Malaysians can contribute to realistically. And I'm really supportive of the Healthcare Reform Commission for transparency, because that's something that the population really cares about in Malaysia at the moment, as we've seen with these discussions around trusting in MySejahtera, our tracing app, and conversations around expanding it. All trust is required for this to take off, but how we build this trust and how we sustain it is really important.
Okay. Yeah.
Thanks, Jeremy.
Thank you, Swan. Now that Minister has had a chance to catch his breath, I see he doesn't need to drink, which is very good for a health minister. Right, really, Minister had asked for a robust, no-holds-barred dialogue, and I think from the questions and the upvotings, yes, they will be quite robust. And there are so many questions about politics, Minister. So if you don't mind, let me ask you about politics. And as I read these questions, I am reminded of the words of the conservative writer Thomas Sowell, where he described that the first lesson of economics is scarcity. There is never enough of everything for everyone. The first lesson of politics is to ignore the first lesson of economics, right? And how do you intend to square this circle? And perhaps you could share, incorporate some comments about the Healthcare Reform Commission, and and this concern that the public are asking around what will happen to the sustainability or the endurance of the white paper if another political shakeup occurs?
Yeah, thanks, Jeremy, and thank you for the comments and the observations that I think really push the discussion further. Let me start by touching on the 3 Ps that were raised, and then sort of come back and loop back to the political question. That's still a relatively health question.
Okay.
I was expecting question, when is the general election? That's not a health question. Or maybe it is, yeah, stress, mental health, yeah. On products, and I think this is a very, very important discussion that I had while I was here and while I was in Switzerland. There are very, very key gaps which I think Southeast Asia can fill in very quickly. When I was in Davos, I met with a lot of the senior representatives of the big pharma companies. And they said one of the big problems that they are facing, a corollary of the war in the Ukraine, was that a lot of clinical research and trials that they undertook was actually done in Russia and Ukraine because they had good patient enrollment in those countries. And coincidentally, I was there for that exact reason. As Minister of Health, I'm also the chairman of Clinical Research Malaysia, which is a company under the Ministry of Health, and it's a one-stop center for coordinating clinical research. So I said, why don't you all seriously think of pivoting a lot of your clinical research to Malaysia and by extension to Southeast Asia? 680 million people in ASEAN. Between Singapore and Malaysia, we're the 2 leading countries when it comes to industry-sponsored clinical research. Our regulatory approval is less than 30 days, I think, Singapore and Malaysia. Ethics committee approval, less than 2 months. Very, very competitive. So I think I raised this with Minister Ong Yi Kang, and we agreed that it is something that we should pursue at a regional level. Singapore can focus on certain aspects of clinical research, first in human, phase 3, Malaysia, and then we can also work with like-minded ASEAN countries, Indonesia, more scale. So I think that on products and working together with the private sector, clinical research not only is a gap because of the war, but it's a high economic spin-off from clinical research because of the investigators that you have to employ, that you have to pay, and the sort of procedures that need to take place. Platform, wonderful observation. And again, I was at Asia Tech at Singapore yesterday, 2 days ago, and I spoke about how when I came into the Ministry of Health in Malaysia, I saw a mountain of data just sitting there. I was just, it was just staring back at me. I was staring back at it. I wasn't doing anything. I wasn't doing anything. And it has this wonderful name, Malaysian Health Data Warehouse. Grandiose name. So I told the small team, and then we got developers come in from outside. I said, look, why don't we showcase the data we have first with COVID? So we got these kids, these bright kids, did it for free. They developed the COVID Now website. And we literally, that's just the front-facing data. Behind that is a whole load of data that we dump on GitHub every day. Line-listed data, anonymized of course, but line-listed. Rich data about line-listed COVID cases, what vaccination they took, when they took the vaccination. Really a gold mine for research and for people who want to use that data for technology and for investments. Well, now what I've done is I've challenged the team to say, okay, I don't want COVID Now anymore. I want MOH Now. So in July, we'll be launching MOH Now, which is not just the COVID data, but a whole bunch of other data from hospital level. I have both my Deputy Director Generals here for Public Health, Dr. Chong, Dr. Asmayani for the medical services. I said, look, it's anonymized, but it's as detailed as possible, but this will unlock so much. in terms of solutions and investments by the private sector. Processes, another important point, and that speaks to regulation. So what we want to do is medicine or healthcare is highly regulated, and it should remain so because of what's at stake. But these regulations should not get in the way of things. And we saw how regulations were truncated during the vaccine process for COVID-19. It didn't mean that anything was sacrificed in terms of safety, in terms of efficacy, in terms of stability. All it meant was that certain procedures were done in parallel and were done much quicker. We can do the same. So I've been trying to work with my regulatory authorities, pharmaceutical regulatory authorities, medical devices authority, to say, look, let's have a lighter touch. Let's create safe sandboxes for people to come in and people to understand our needs statement, to present use cases, and to see whether it works or not. So I think in terms of regulatory reform, it's also something that is on the cards. You spoke of aging well, and I think this is a point that I just left at the end, not because it's not important, but because I ran out of time. And I think aging well should not just sit with the Ministry of Health. This is a cross-ministry. This is one of those which really needs to work together. Ministry of Housing, Ministry of Social Welfare, local governments. It's how you redesign buildings. It's how you redesign public transportation. So it's actually a multi-ministerial effort. For us in Malaysia, it's under the Minister of Women, Family and Community Development. Obviously, we have a big say in this. But the other thing which I did forget to mention, which you raised, was palliative care. Now, palliative care is very important, not just because we want people to also not just live, but also pass in a dignified manner. But there is a resource issue here as well. We see a lot of our patients passing in hospitals when they shouldn't need to pass in hospitals. It's not just about resources, it's also about dignity and comfort. I think if you could ask many people who see the end of days in hospital where they would prefer to do so, they would say at home and not in hospital, unless you have terribly high hopes of a Hail Mary at the end of the day. So I think there needs to be more investment in the spectrum, not preventive and promotive as well, promotive healthcare, but also at the end, which is palliative healthcare. Just a final one, if I may. How do we do this? Because the question was the question on how we do the financing. Is it going to be difficult? Of course, it's going to be difficult. We have a list of things we must do after the elections. GST. We must look at rationalizing subsidy. This is Malaysia and healthcare. Not going to be easy, but it has to be sequenced properly.
Thank you so much. And as chair of one of Singapore's two local hospices, I am very gratified by your comments about end-of-life care. Comment to any Ministry of Health officials that not just Malaysia, but Indonesia has also released into the public domain BPJS data on a de-identified basis to allow for many clever minds to interrogate the data and help make the system better. We are pretty short of time, so I would want to prioritize questions that people ask live. There are 2 microphones on either side. We have time for 2 questions, so whoever reaches the microphones first are kind of survivor type. Please get to the mic. First in line means you can ask the question. And while you are getting up there, really, Minister, we do have a somewhat cheeky question here that I feel empowered to ask, because as I hear you describe the Khairy Minister Ikang bromance, the question is, in future-proofing public healthcare, what do you think are some of the lessons Singapore can learn from Malaysia? And don't be shy. Call it as it is. Singaporeans have very thick skin, so we can take it.
I think we do pay a lot of emphasis on equitability,
yes.
Not just locally but globally as well. And I singled out our experience with the Drugs for Neglected Disease Initiative because this affects the global south. So when we work with DNDI to invoke the compulsory license, it's really a bloody nose to the pharma companies. And we hope Singapore can stand in solidarity with us from time to time when we do this.
Noted clearly on that. Thank you. We have two ladies at our, okay, yeah, Joan, please. Yeah, can you introduce yourself and then ask the question?
Is this on now?
Yes,
Okay.
it is.
Perfect. Thank you so much, Jeremy, Sian, and also Dr. Ong. And YB, very nice to always meet a fellow Malaysian, as well as a fellow UWC alumni.
Oh man,
always
this
proud.
is Hotel Singapore. Please,
Yes.
Joan, go ahead.
Thank you for the wonderful rates that you have been providing. My name is Joan, and I'm the founder and CEO for Thoughtful. We're actually a digital mental health company that's a portfolio company of Penjana Capital, as well as Haizam's fund, Hive Southeast Asia. So the question specifically that I have, and I'm going to take Dr. Jeremy's candidness with complete, complete straightforwardness, because I'm going to be quite straightforward. Yes. The question is on process. And so I think when it comes to PPP especially, and when it comes to PPP with startups, the frontier of digital innovation, the people who are actually innovating quickly, who are really future-proofing a lot of the things that are happening in the ecosystem, not just in mental health, but also in healthcare in general. I think a very typical problem that we will face, and this is, hand on heart, something that I know a lot of people will relate to, is that we will approach the behemoth of MOH or KKM. There will be some form of, department that you will be connected to, and then it becomes a dark web. And then everyone will have to figure out the ins and outs, who to talk to, and you kind of get bounced around. And so I think one of the main questions here as we future-proof is, what are we doing to ensure the processes will enable us to future-proof quickly and also effectively?
Yeah. So there is a dark web, and Minister Khairy, can you shed some light on this?
So this sounds very discouraging, but my solution to too much bureaucracy is creating more bureaucracy. Let me explain this. There doesn't exist in MOH right now, and this is why you end up in a dark web. A department, sorry to use the word department or a division that looks at medical industry development. It's disparate. It's across. So pharma, you have to talk to National Pharmaceutical Regulatory Authority, medical devices, you have to talk to MDA, and hospitals, you have to talk to the medical services. So what I'm creating is a lean and small medical industry development division that caters precisely to startups, companies, providers, solution providers that want to come and quickly test, iterate your solutions in the Ministry of Health. So let me set it up and make sure that it's not bureaucracy as usual, BAU, but rather something that can facilitate you and ensure that you're not going to be in the dark web.
Okay, then maybe I'll take the bus back to Malaysia after this.
Thank you.
And the causeway is open, so don't worry.
Yeah.
All right.
Don't forget who funds you.
Yes. Yes, sir, I won't forget. Thank
Thank
you
very
YB.
much, Joan. And can we have the next question, please?
Hi, I'm Hui Kun. I'm from the Yonglulin School of Medicine.
Wait, are you Malaysian?
I'm Singaporean.
Oh, thank God. Please.
I'm actually an administrator with the Yonglulin School of Medicine, but I'm here to ask my question actually from the perspective of a gerontologist. That's my training. And I just, this is something that I think in our class discuss a lot about. I'm currently 46 years old, at the middle age that actually we think has really shifted to the 50s and 60s people, right, because of the aging population. And I just want to kind of like play devil's advocate here because we're talking about future proving. So, and that is with regards to the concept of aging in place.
Yes.
And also dying in hospital. Because this is something that we, amongst my cohort, people of around this age group, we've had a lot of discussion and debate about that, and we question whether those concepts are based on people who are currently old, in the definition of, I guess, in public healthcare, many of them are defined as 65 and above, right?
Okay.
Chronologically aged. But whereas if you look at so when you talk about things like aging in place and you talk about not wanting to die in hospitals, people who are currently old, we have heard of actually people who don't want to die at home.
Okay.
And that's because maybe ethnically there is this concept that is very inauspicious.
My apologies, we couldn't, but we're a bit short of time. Can you get to the question?
Sure,
Sorry.
Sure. So,
Thank you.
question, I want to challenge this view,
Okay.
whether people really do want to die at home,
Okay.
right? Because they may prefer to die in hospital because of the traditional superstitions about causing the property prices to drop.
Yes.
Maybe, Jeremy,
Please, Minister.
I could answer that by saying that that's why the reforms need to be made so that it's patient-centered. I think that's really the point here. So at the moment, the patient-centricness of the system is perhaps lacking, that the patient is not offered the choice he or she might have if you design something that's more patient-centered, better palliative care, better long-term care at home, if you choose to be at home. And of course, if you don't choose to be at home, then we can still provide those services at the hospital.
Yeah, so it's really around future-proofing to allow for that plurality that different patients, different citizens may want different things. We are down to the wire, so I do want to ask Swan first for her wishes for Malaysia as a proud Malaysian, right? That you can feed back to Minister Khairy, and then I'll ask Sian to input. Swan, please.
Thanks, Jeremy. I certainly don't profess to speak for my entire country.
No, that is his job.
That's true. That is. I wouldn't want to take the job away from Minister Khairy, let's just put it that way. I guess what I hope to see for Malaysia in particular in health, like what is something Minister Khairy has alluded to in his past engagements, which is to view health not as investment in health, not just as a line item in a budget, but as investment into the population's future well-being, and not just mental and physical well-being, but also the economic well-being and ability to generate for the rest of the country. I think that's crucially important, and we really do need that mindset shift. But mindset shifts are like turning an aircraft carrier. They're unwieldy, heavy, large, and difficult, and takes a very long time. But we have to also remember to not be disenchanted by the journey and focus on what we can do in the interim rather than focus too much on the turning activity itself.
Thank you, Swan.
Yeah,
well,
thank
it's
you.
said that politics is the art of the possible. So I think you're in very good hands. Sian?
Are you going to ask me what it's like to be an American?
No.
Okay.
I have utmost sympathy for
I
you.
get in more trouble than you, I think. So thank
please.
you. I'm just going to continue beating on the same drum around partnerships, because I think if we are to advance into the future, partnerships, I'm going to bring my bleeding heart epidemiology perspective into the private sector, which is we want to be seen as partners. We really want to contribute in a very positive manner. And I'll just share a very short story. I was at an ASEAN meeting. I was presenting at an ASEAN meeting about value-based healthcare. Some of you know I used to talk a lot about value-based healthcare. And I had one of the government officials from I will not name which country, say to me, wait a minute, aren't you a vendor? Don't you sell us widgets? Well, yes. However, we also have an investment in the overall healthcare system and in the health of the population. So from the private sector, I want to emphasize that we want to be your partners. We don't just want to be your vendors. Thank you so much.
And and maybe, really, Minister, can I ask you to respond very quickly to the two ladies, and also address the last question? What would you like to see Singapore and Malaysia healthcare progressing together in the future, partnering with each other?
Yeah, thanks. A vendor saying that they want to be partner, double-edged sword. First of all, Dr. Ong spoke about health as investment and how we're going to make sure that this happens. And my answer is strike while the iron is hot. We've always had this problem trying to get enough funding for healthcare because of the tragedy of the horizon. It's something that happens later. It's something that we can put off till later. It doesn't affect us now. COVID, clear and present danger. Hi, Minister of Finance, I need 5 billion ringgit to buy vaccines. Please have it, 5 billion ringgit. Pre-COVID, hi, Minister of Finance, I need 5 billion ringgit to upgrade hospitals. Here's 500 million ringgit. So use the present, emotional blackmail. If it wasn't for us, you'd be dead.
Okay.
No, seriously.
Yeah. Yep.
The public supports health care professionals now.
Never waste a good crisis.
The public wants resilient healthcare systems now. So this is the time that all of you and all of us should ask for our fair share. Now, coming back to vendor.
Yes, vendor.
Dr. Vendor, Dr. Sian. But seriously, I just want to give one example of wasted opportunity. This is talking about working with private clinics in Malaysia. Dr. Chong is my Deputy Director of Public Health, looks after public health, primary health care. We have 1,300 odd public clinics under MOH across Malaysia. 1,000 clinics, rural clinics, smaller clinics. But we have 8,000 general practitioners, private, not utilized. We used them during the pandemic to do vaccination. So what we want to do now is say, look, let's have a new chapter, let's work together. So not just screening, let's go for NCD treatment, let's do it together. Yep. Otherwise, it's a terrible, terrible waste of space. Again, use the opportunity from this crisis. And Jeremy, last point, I know we're running out of time. Singapore, Malaysia, I think one area which I think we can really, really work on is digital health. I think if we get the regulation in place, it can be seamless, yes, both ways. And that's something that, of course, the bromance is working on. Minister Ong and I are working on. Thank you.
Thank you so much, Minister, and thank you to Swan and Sian. Thank you very much, everyone, and we'll hand the time back to our MC.
Thank you, Minister Khairy, Prof. Lim, Dr. Lay, and Dr. Ong for the insightful discussion on future-proofing healthcare. Before we wrap up the session, I would like to invite Prof. Lim to present a token of appreciation to our panelists. Dr. Sian Lay. And Dr. Ong Swan Lee. This calligraphy scroll is a replica of the memento presented to our school's benefactor, the late Professor Saw Swee Hock, when the school was officially established in 2011. Ladies and gentlemen, the phrase 人人健康, read from your right to left, means health for all, underlying the school's commitment to turn discovery into healthier communities. The very same characters, 康健人人, from left to right, means all for health, highlighting how a good health provides a critical foundation for a strong population. Thank you, Minister Khairy, Prof. Tan, Associate Prof. Su, Associate Prof. Lim, Dr. Lay, and Dr. Ong.